دكتور بروف دكتور كمال عكاشة البروفيسور دكتور كمال عكاشة هو رئيس وحدة أمراض الكلى في طنطا ووالد دكتور كمال أصل داود داروز Aldosterone and Diabetic controls. With my professors and colleagues, and it's a great chance actually to meet all my friends from here and there. And thank you to the head and the chairperson for the nice introduction. We're not going so far, still talking about the same theme, dryness and diabetic nephropathy and chronic kidney disease. So I'd like to take a quote from Dr. Ahmed Adam when he asked me last year to give this talk in the Egyptian Center of Nephrology. The old friend, the newcomer, Aldosterone for diabetic nephropathy. So it's coming back again, although it's very old. It's just a very brief agenda. I'm going to talk very briefly about the diabetic nephropathy and role of aldosterone in pathogenesis of the nephropathy and aldosterone antagonism. Does it have role on the progression of chronic kidney disease or diabetic nephropathy? And finally, I would like just to highlight one clinical situation that we have in diabetic nephropathy, which is renal tubular acidosis and its relation to aldosterone. By definition, diabetic nephropathy is clinical syndrome, just in front of my endocrinologist, so I cannot be like shy a little bit, but it's okay if you allow me. Diabetic nephropathy is a clinical syndrome that characterized by the following: persistent albuminuria, more than 30 milligrams a day, or according to the new classification, urinary albumin-creatinine ratio, or more than 20 micrograms per minute. That's confirmed on at least 2 or 3 occasions, as we will know, associated usually with progressive decline of the GFR and arterial blood pressure. And of course, there is long-standing history with diabetes, with or without retinopathy, and renal biopsy confirmation is rare, especially in cases which will show clear cut for evidence of diabetic nephropathy. I think the interpretation has been changed in the last data and KDIGO in terms of albuminuria. There is no more micro or macroproteinuria, and just get some terminologies in terms of A1, A2, A3, depending on the level of microalbuminuria or albuminuria, sorry. So we just A1 means normal albuminuria, A2 it's more than 300 up to 50 up to 300, or A3 which is moderate or moderate to severe with proteinuria or albuminuria more than 300. And of course, retinopathy and type 1 diabetes at least duration of 5 to 10 years to develop diabetic nephropathy. So that was the terminology of diabetic kidney disease. So we went to suspect non-diabetic kidney disease. I mean patient with diabetes and presented with element of renal impairment. Thus all cases, of diabetic are considered as diabetic kidney disease, or there is some entity of patients are not fulfilling this criteria. All these patient, if you have a patient with diabetes and present with absence of diabetic retinopathy, or have a decline in the GFR, or sudden onset of nephrotic syndrome, or there is a refractory hypertension, or there is any evidence of urinary sediment or active sediment in the urine, or signs or symptoms of systemic illness, and there is more than 50% reduction in the GFR after starting RAS blockade, for example, ARBs or ACE inhibitors. And data from UKBD study just showed very clearly that the incidence of cardiovascular visit is related to the evidence of the albuminuria in general. If you can see here, if there is no albuminuria, the incidence of cardiovascular visit is just 1.4. As long as the progression of albuminuria increased, the incidence of cardiovascular disease also associated, increased also, and if the patient got in association to albuminuria evidence of decline of the GFR or the increase of the serum creatinine, and the incidence will be doubled almost 4-5 times. So if you, in the general population, the incidence of cardiovascular disease, if you say it's 1, then it increases up to 20 times in patient with chronic kidney disease. And in patients with diabetic nephropathy, if you have good outcome, then you are going to have, if you have improving outcome of diabetic nephropathy, this is associated with prevention of cardiovascular disease and prevention of end-stage renal disease. And this is a renal injury triad. It is related to angiotensin and proteinuria and hypertension. This is very harmful triad for diabetic patients. And these are the treatment strategy for diabetic nephropathy in terms of lowering the blood pressure, depending upon the target or goal of blood pressure. This is a new data from KDIGO or EDA. They just recommend less than 140 by 90. Or in certain situations, you may go less than 130 by 80. And of course, treatment of reducing proteinuria by the current medications, inhibition of renal angiotensin system, and multiple risk factor intervention like hyperglycemia, hyperlipidemia, physical activity, aspirin, and so forth. And as we all know, this is a two landmark studies for management of proteinuria and prevention of decline in GFR, which are renal and IDENT trials. Although these trials showed marvelously that the incidence or the reduction of microalbuminuria or albuminuria and decline of GFR was very evident in this study, and there is subgroup analysis of these patients. They took the elderly population. These two medications, either losartan or irbesartan, they didn't show decline and improvement of the normal decline of the GFR in elderly. Therefore, I think there is something still behind these two RAS blockade, either ARBs or ACE or other RAS blockade, still in the hiding, and still need to be shown and need to be exhausted, investigated it to show if there is a relation with the other factor in the RAS blockade has a relation to decline of the GFR or proteinuria. That we are going to see in the next few slides. So, if there is any role for aldosterone in prevention or management of diabetic nephropathy or decline of the GFR or so forth, as I mentioned before, I took this quotation from Dr. Ahmed Adam, professor of nephrology at Alexandria, when he gave it to me last year, as aldosterone is an old friend and a newcomer. I think this diagram is well known to all of us since we started in the diabetic patient. The mechanism of diabetic nephropathy starts at this point by overexcitation of angiotensin 2 with either hemodynamic or non-hemodynamic changes associated with glomerular hyperfiltration and glomerular hypertension that will lead to proteinuria and injury to the glomerular cells. And at the same time, this angiotensin 2 may be associated with non-hemodynamic changes, including cytokine release, and which finally will lead to sclerosis and fibrosis of the glomeruli. In this, as you can see here, the proteinuria and injury to the glomerular cell and sclerosis are the leading process for end-stage renal disease and progression to end-stage. So what else? Then we have here this hidden factor, aldosterone, which is the result from angiotensin 2 activation to further steps, and finally it will lead to either vasoconstriction or aldosterone. Aldosterone will lead to either direct toxicity, direct effect on the glomeruli, with inducing sclerosis and fibrosis, or proteinuria, and finally will affect the glomeruli by glomerular sclerosis and end-stage kidney disease. Again, this is the role of the aldosterone. I maybe just make it more systematized and just bring figures to explain it. This is the activation of aldosterone in diabetic patients through activation of angiotensin 2. Then it will lead to accumulation of aldosterone and mineralocorticoid activity, which will lead to, as I mentioned already, cytokine release and activation of vascular endothelial growth factor with more selectivity of the glomerular capillary, which will lead to more proteinuria, or release of some stress factors like in the factor kappa B or MCB or whatever, and also induce, I'm going just to show a slide how aldosterone also will be associated with insulin resistance, and of course induce systemic hypertension as a result of salt and water retention. And all of these factors together will lead to progression of atherosclerosis and nephrotic syndrome and hypertension, and of course lead to cardiovascular events. This is very nice slide. You may share this with me, and talk about Dr. Magahid was talking about the relation with diabetic patients and treating the kidney as a target for management of diabetes, or a cause for diabetes. Because you know this LGBT or other factors. Here is another mechanism, or another hidden mechanism for in diabetic patients, which is glomerular insulin metabolic signaling or metabolic pathway, and its relation to angiotensin 2 and aldosterone. You can see here, this is the metabolic signaling pathway, and it's very essential for the whole compartment of the glomeruli to work. For example, it will just affect the podocyte by just maintaining the integrity of the podocyte. It may maintain the capillary integrity and release of some vasodilator material like nitric oxide. And it will also affect the mesangial integrity and mesangial function as a matrix, and as well as the skeleton for the kidney or the glomeruli. If there is affection of the metabolic pathway, then all of these elements will be affected greatly. So you can see here aldosterone and aldosterone expression and mineralocorticoid expression. It will prevent or block this pathway. Then accordingly, the podocyte, capillary matrix and the mesangial matrix will be affected, and there is evidence AKR or acute kidney injury. I think we need to summarize all the events related to aldosterone in patients with diabetic nephropathy. It will either induce glomerulosclerosis in the kidney, or ventricular hypertrophy, cardiac fibrosis, and other sequelae for the heart. And of course, it will induce vascular endothelial dysfunction, inflammation, and oxidative stasis. Just I'm going to go very briefly through some studies. Back in 1999, they just did some experimental study on rats which fed on salt, and the rats were very prone to have stroke depending on, they make it like salt sensitive. And they just studied the impact of this salt sensitivity and making this rat hypertensive on the aldosterone level and the urinary excretion rate, and glomerular lesion and the vascular lesion. They found very clearly that the rats who fed on aldosterone, the incidence of the plasma aldosterone was very high, and the glomerular lesion was very high also, and the vascular lesion was more than those without the placebo or the vehicle, or urinary protein excretion was the highest among the treated rats with captopril, for example, captopril with aldosterone, captopril with aldosterone around large dose, or aldosterone alone. They just concluded from this study that it was very earlier study in 1999 to just tackle aldosterone as one of the markers for progression of diabetic nephropathy or leading cause for diabetic nephropathy. These findings support the major role of aldosterone in the development of malignant nephrosclerosis, insulin drinking, prone rats, salt-sensitive prone rats, independent on the effect of blood pressure. So it is aldosterone effect, not only blood pressure effect. I think other studies were talking the same theme we talked about, and they just take it to clinical application. For example, if we just do diabetics in general, we all know that diabetics has no role for management of proteinuria or diabetic nephropathy. But aldosterone itself, antagonist, aldosterone antagonist appear to reduce the proteinuria when used alone and to have a lytic effect on proteinuria when used with others, blockade of rats like ARBs or ACE inhibitors. The problem with adding aldosterone antagonist to ACE inhibitor or other RAS blockade is the common care in this point, which is hyperkalemia. That's why we should be very cautious and very careful when using aldosterone antagonist in combination with aldosterone with other RAS blockade. So we have to ask ourselves, can blood blockade with RAS improve renal outcome in diabetic nephropathy? Okay. For example, if we just block the angiotensin 1 to angiotensin 2 with ACE inhibitor, or to block angiotensin 2 to AT1 receptor blockade with ARBs, or to block the conversion to further steps with mineralocorticoid antagonists like spironolactone or ibuprofen, does it have an impact on the progression? That we are going to see very soon. Okay, this data from Jason that is showing that addition of angiotensin receptor blockade or mineralocorticoid activity to maximize the effect of this RAS blockade or not. And this study design was just carried out in diabetic patient, diabetic nephropathy patient, and the patient was randomized to receive placebo and medication. And the study population, patient with diabetic with microalbuminuria, despite they are both in maximal ACE inhibition with lisinopril and lisinopril 80 milligram. Patient was assigned to either receive additive ARBs or to receive spironolactone in addition, or aldosterone 25 milligram plus placebo, of course. And the primary outcome is the change for albuminuria, and the secondary outcome is safety regarding the decline of GFR and hyperkalemia. Okay, the follow-up of this study was 52 weeks, and the data of this study, and this is a randomization again for this study. The data of this study have clearly shown that the group who received aldosterone antagonist, this group, the reduction of microalbuminuria was almost double the reduction in patients who received ACE plus RBs. So I think this is a clear evidence that aldosterone can be used in some patients, provided there is no hyperkalemia or you are not afraid of that to reduce the microalbuminuria or the nephropathy. Although hypertension or when arterial blood pressure does not change because the patients were already on the maximum blood pressure control, which was 130 by 80. So the theme here was only just to tackle the impact on the microalbuminuria. Another study for one of the newer aldosterone antagonist. This is not new, it's more than 8 years now or 10 years, but it's not being made or just involved in the clinical practice too much, but I think it's available in the market. They just looked this eplerenone, and it was a randomized study. Patient with hypertension was receiving some of the one of the arms, and the patient was assigned to either receive placebo or to receive eplerenone 50 milligram or 100 milligram, and were randomized according to the number were almost the same in this group of patients, were almost 270 patients, and they found that the microalbuminuria were less in patients who received 50 milligram. And the recommendation from this study, also the GFR decline was just modest among the patients who received 50 milligram here in this study. And they concluded from this study that eplerenone in a dose of 50 or 100 milligram added to ACE inhibition in enalapril, called enalapril, not ARBs, resulted in substantial significant reduction in albuminuria as measured by urinary albumin-creatinine ratio, and they mentioned that a dose of 50 milligram is ideal dose just to get your maximum effect on microalbuminuria. And this meta-analysis was just carried out in studied 15 articles talking about the dual effect of the aldosterone antagonist and ACE ARBs, and their impact on the proteinuria. I'm sorry if it's not clear, or hyperkalemia, or hypertension, and the reduction in the GFR. And the results were as follows. The reduction of the proteinuria among all these studies were 55%, and the blood pressure reduction was 40%, and the GFR decline were 25%. And regarding the hyperkalemia, they found only one study among 8 patients, there was only hyperkalemia. We are just talking about the safety, so it's clear just if you use it and you make follow-up, then I think you are not going to get harm to the patient that much if you follow the instruction. Now, we are just going to just a piece of clinical implication of the aldosterone and diabetic nephropathy patient in terms of renal tubular acidosis and how aldosterone works in this area. We know that aldosterone and just make a good job in renal acidification in the distal collecting system, and favor hydrogen and potassium secretion through enhanced sodium transport, and recruits more amiloride since the sodium channel in the luminal membrane of the collecting system, and enhance hydrogen ATPase activity in the cortical and medullary collecting tube. And aldosterone also have an effect on ammonia excretion by increasing ammonia tests. And this is the clinical syndrome or the clinical situation that we have patients with among diabetic nephropathy is one of these can just be considered as one of these renal tubular acidosis syndrome. And this disorder is characterized by modest hyperkalemic metabolic acidosis with normal align gap associated with hyperkalemia, and this condition occurs primarily due to increased urinary ammonia excretion. As we mentioned, this is one of the major roles for aldosterone, and hypoaldosteronism is considered the most common etiology. Just very briefly, I'm going to highlight it. Renal tubular acidosis type 4. It is just maybe due to acquired or to acquired causes, either through reduction of the urine, whatever the etiology, and diabetic nephropathy is one of these factors which reduce the urine. It may be also non-steroidal anti-inflammatory interstitial nephritis, or it may be associated with normal renal in some situations like ACE or ARBs or heparin or primary adrenal response. And my professors and the endocrinologists are available here who can ask them about this. And decreased response to aldosterone, like medication which are used in clinical practice, like aldosterone, like tacrolimus, like cyclosporin, intermediate, and tubular interstitial disease like and sickle cell syndrome, amyloidosis, and diabetes. All these factors are associated with type 4 renal tubular acidosis. And the Treatment is just depend on the etiology, and potassium-containing diuretics should be withdrawn and avoided in such patients, and fluorocortisone therapy may be useful and may be useful in hypoaldosteronism, preferably in condition, in combination with loop diuretics such as furosemide, to reduce the risk of extracellular fluid volume or volume expansion. And to summarize, diabetic kidney is related to end-stage renal disease and cardiovascular morbidity and mortality, and aldosterone may have very deleterious effects on the in the progression of the renal function in diabetic nephropathy patient, and aldosterone antagonists may play an important role in blood pressure control, urinary albumin excretion rate, alone or in combination with other RAS blockade agents like ACE or ARBs. And hypoaldosteronism is the main cause for type 4 renal tubular acidosis. And thank you for your attention.
Thank you very much. The next speaker will be